Good afternoon. This is Dr. Julie Servoss. Welcome to our webinar, MIPS is Redefining Success for Gastroenterologists, Future Trends in Gastroenterology Reimbursement. Again, I'm Julie Servoss. I am the Medical Director of Gastroenterology for Modernizing Medicine, and with me this afternoon is Ida Mantashi. Ida, would you like to say hi?
Hi, everybody. My name is Ida Mantashi. I'm a Senior Compliance Product Manager.
Wonderful. Let's get started. So, the outline for our conversation today, value-based payments. How did we get here? What are the new rules for payment? How will we get paid in the future? And how can GMed and Modernizing Medicine increase the reimbursement pie? Ida and I will be speaking for about 30 to 35 minutes, and then we will take questions. I just wanted to point out that you'll be able to type your questions into the GoToWebinar dialog box on the right-hand side of your screen. All right, so why is value-based healthcare here? Why is it not going away? The first part of the picture are physician earnings. When we look at this pie chart and examine Medicare benefit payments, and this is from 2013, physician payments represent 12% of the payout. We're talking about $583 billion of total Medicare benefit payments, of which, again, 12% go to physicians. Specialists like us, gastroenterologists, cost more. Now, this slide in front of you does not include gastroenterologists, but I wanted to give you an idea of how much we get paid. So this chart shows in 2012 about $77 billion in Medicare disclosed payments. The updated numbers for 2014 for gastroenterologists is the payment is about $1.63 billion. So we're really in the mix of the top 10 to 12 medical subspecialists care payments. We represent approximately 1.5% of physicians and 2.1% of the Medicare spend. So how does CMS plan to rein in costs? Better, smarter, and healthier healthcare. The CMS announcement in January 2015 notified us that as of 2016, 85% of all traditional Medicare payments would go to quality or value. And their goal is that 90% of payments by 2018 will be by quality or value, not by volume. Now, how does this work? The name is MACRA, Medicare Access and CHIP Reauthorization Act of 2015. This repeals the sustainable growth rate formula that we have all been familiar with for many years, and it changes the way that Medicare rewards clinicians for value over volume. First, streamlining multiple quality programs under what is called the Merit-Based Incentive Payments System, or MIPS. There also is a way to provide bonus payments for participation in eligible alternative payment models, but for the most part, we gastroenterologists will not qualify for that. So let us focus on MIPS, the Merit-Based Incentive Payment System. It is a modified fee-for-service program, and more importantly, it's a rebranding of PQRS, Meaningful Use, and the value-based modifier. It's combining all of the incentive programs and lumping them together. Specifically, the rebranding of Meaningful Use, or MU3, will be the use of technology. That means that Meaningful Use 3 will focus on interoperability, sharing of data with an EHR, and closing the referral loop. EHRs that block interoperability will not be tolerated. Physicians in the top 75% of physicians above the performance threshold will split another $500 million per year in Medicare reimbursement. Okay, so let's deconstruct MIPS and understand what this MIPS composite score is. A single MIPS composite performance score will factor in performance in 4 weighted performance categories. The first one you see to the left with the star is quality. The second is resource use or cost. The third is clinical practice improvement activities. And the fourth is meaningful use of certified EHR technology. all 4 of those will be collected together to calculate a MIPS composite performance score. So let's break down a little bit further. The MIPS adjustments, the change in our reimbursement, will start in 2019 based upon our performance in 2017. So again, what we report and how we perform in 2017 will affect our reimbursement from Medicare in 2019. What you see in the slide before you is that in 2019, the adjustments will be a plus, an incentive payment, a bonus of 4%, or a penalty of downwards to -4%. In 2020, you see the range is ±5%. In 2021, ±7%. And then in 2022, ±9%. So again, these represent adjustments to the provider's base rate of Medicare Part B payment beginning in 2019. So let's reemphasize the timeline again. The MIPS measures 2017 performance and adjusts payments in 2019. So we cannot wait until 2019. Our payments will be affected based upon what we report next year. Your MIPS score will be posted on this website. See Medicare.gov, Physician Compare. This will be public information. You see location, any user, any patient can go in and type in zip code, your practice name, your name, and you will see your MIPS score. All right, let's break down the 4 components. The first one is quality. And we discuss this first because it is the biggest part of the pie. It's 50% of that MIPS composite score. And you see on that pie chart that the parentheses of PQRS. So PQRS equals quality in MIPS reporting. We're going to be judged on quality measures that right now aren't really as specific as we would like for gastroenterologists. But later in the slide presentation, the webinar, Ida and I will discuss how gGastro and Modernizing Medicine together are going to help you with these quality measures. So what does MIPS mean by quality? As I said, when you see quality at 50% of your MIPS composite score, you should think PQRS measures. It's a change from 50% of Medicare patients to 90% of all payer patients. This is the proposed rule. And we will have to report on at least 6 quality measures. Among those 6, we have to have 1 cross-cutting measure, 1 outcomes measure, and there is no restriction on the clinical quality domains. Furthermore, there's no penalty for submitting more than 6 measures. A maximum of 10 points is going to be awarded for each measure, and then there will be bonus points awarded for outcomes and high priority measures. And again, this is the calculation and scoring in that MIPS composite score. The next 3 slides, I'm going to show you existing gGastro measures that you have access to already and may be using. The measures listed here are the process measures. And I have put the PQRS measure number on the left-hand side, emphasize the part that this is process, and then you can see the title of these PQRS measures. What I also wanted to highlight is that really only that second measure listed, colorectal cancer screening, is specific for gastroenterologists. The other ones are generally used by internal medicine and other subspecialties, but they're not as specific as we would like as gastroenterologists. And again, we're going to discuss this a little bit later. This slide shows the 3 outcome measures you currently have to choose from. And again, this is diabetes management, hypertension management, so not necessarily the primary purpose or role that we play as gastroenterologists. And finally, this slide, these are the existing gGastro cross-cutting measures. There are 4 in existence. The first one, you see documentation of current medications in the medical record, very common across all specialties. And then again, we have some that may or may not be as valuable for gastroenterologists or highly used. Cessation, screening and cessation for tobacco use, controlling high blood pressure, and again, closing the referral loop. So again, not as specific as we would like for gastroenterology. Okay, so that was one of 4 components of MIPS. Let's move to the second component, advancing care, or what is also known as meaningful use. If you look at the pie chart, you see that this component represents 25% of the MIPS score. The good news is that the number of required measures has been cut down to only 6 measures out of 10 that had existed previously for meaningful use. Those 6 measures focus predominantly on patient engagement and interoperability. Examples in gGastro right now are the existing patient portal. That obviously is key for patient engagement. And with respect to interoperability, immunization reporting, which many of you may also do. The next piece of the pie in yellow is clinical practice improvement activities. This is a brand new piece for everyone. There will be 2 reporting categories, high improvement and medium improvement score categories. So since this is a brand new piece for everyone, you may be asking yourself the appropriate question, what do they mean by practice improvement activities? I will give you some examples. The first one is around expanded practice access. Examples of this would be same-day appointments for urgent needs, after hours, access to clinician advice. Another category would be population management, monitoring health conditions of individuals to provide timely healthcare interventions or participation in a QCDR. Another category is care coordination, such as timely communication of test results, exchange of clinical information to patients and other providers, and use of remote monitoring or telehealth. Another category is beneficiary engagement, such as the establishment of care plans for individuals with complex care needs, beneficiary self-management assessment and training, and shared decision-making mechanisms. And the final 2, patient safety and practice assessment, the use of clinical or surgical checklists and practice assessments. And the final one is participation in alternative payment modes, but that, again, does not apply for the vast majority of our practices. The fourth and the final piece of the MIPS calculation is called resource utilization, or what is cost. Cost is 10% of the pie. We'll be judged on cost per capita Medicare beneficiary. And there are going to be 2 pieces of this calculation for MIPS. How much we spend, or the cost per beneficiary. And the second piece is what's called an episode calculation, which we'll look at on the next slide. The good news is that providers are not responsible for providing this data. So it's one thing that we do not have to provide for our MIPS reporting. It will be done for us. Resource utilization will be a continuation of 2 measures from the value-based modifier. Again, it's total per cost capita for all beneficiaries, or the Medicare spending for beneficiaries. There are 41 resource measures, and this episode business is a minimum of 20 cases required, and I have pulled the one that is most specific to gastroenterologists. This is one of the episode calculations that may be done for us, colonoscopy and biopsy. And you can see that episodes are triggered by certain CPT or HCPCS codes. All right, so this is what CMS is going to be able to provide for us with respect to quality and cost. What you're looking at on the top is an average. And then on the bottom, what you see is that little red dot is you as a gastroenterologist. And you can see it's almost like a scatter plot with different users. They're comparing us to all other gastroenterologists, all other practices. And where we want to be is in the top right-hand corner, high quality, low cost. The challenge with this is that CMS will give this to us 2 years too late. We don't have time to adjust our practices, our workflow, the measures that we report. We don't have time to make those adjustments because CMS is giving us the data 2 years too late. So we have to come up with a better way to help you as gGastro users and to help our community of gastroenterologists. So, the important part, how do we navigate these waters? So a quote from Albert Einstein, you have to learn the rules of the game and then you have to play better than anyone else. I love sports, so I love this quotation. I think it's absolutely true. We are given a set of rules and criteria and programs that we have to meet and we have to excel. If we want to have incentive payments and be on the positive receiving end of Medicare beneficiary payments, we have to not only play by the rules, we have to do it really well. So this is how we move forward. We have to have user-friendly dashboards that allow us to make real-time, in-the-moment changes to our workflow and what we're doing while we see patients, while our practice is seeing patients and managing care. We have to be able to make changes now to be able to be eligible for payments, incentive payments in 2019. We need automation, automated quality data input. That is key. For those of you who are manually entering information, you know how onerous that is and how time-consuming it is. Thirdly, analytical tools, real-time comparative benchmarking of quality. As I showed you on that scatter plot, which was cost and quality, we need to see how other gGastro users and how our community of gastroenterologists is performing so that we know the benchmarks. We are going to be compared to our peers in MIPS, and we have to know where each of us as individual practitioners sit. We need financial visibility to improve our bottom line in operations. And then finally, interoperability, as I mentioned, with Meaningful Use 3 is going to be another key component. All right, so the gGastro process for 2016, the current year. gGastro users, you will continue to use your existing ECQMs, your clinical quality measures, for reporting for PQRS and meaningful use. And here are the take-home points. If you are currently reporting ECQMs, there is no change in your workflow. If you are currently reporting via GI Quick or another registry, these methods are still available to you. And now, the really important part, what happens in 2017 when MIPS reporting begins? And this is not too far off in the future, so we have to be prepared. We have to know the information and our strategies. There are going to be 3 options for reporting, and CMS just released this on September 8th, so this is the up-to-date reporting options for you. Number 1, providing some data, which will allow you to avoid a penalty. Number 2, you can participate for part of the calendar year. Or option number 3, you can participate for the full calendar year in MIPS reporting. Let's break this down. Okay, so again, MIPS 2017 reporting option number 1, you provide some data to CMS and MIPS. As long as you submit some data after January 1st, you will avoid a negative payment adjustment or penalty. Some data. Let's focus on that. Here are the take-home points. You will use your gGastro MIPS reporting tool, which Ida will show you subsequently. You're going to use this reporting tool for your submission. And 2017 is the year that you and your practice prepare for full MIPS participation in 2018. So CMS is cutting us a little bit of slack in 2017 and allowing individual practitioners and their practices to prepare for that 4-component reporting for MIPS. Let's move on to our second option. Participate for part of the calendar year. You may choose to provide data for a reduced number of days. If you do so, you could qualify for a small positive adjustment. And that qualifier is very important. This is directly from CMS. You could qualify for a small positive adjustment if you report for part of the calendar year. And here's the take-home point. You will use the MIPS reporting tool that's built into gGastro that, again, Ida will show you in a few slides, for any duration that you as a user or the practice selects. Any duration. There is a lot of flexibility here. The final option is participating for the full calendar year. You may choose to provide data for the full calendar year, and you could qualify for a modest positive adjustment. And again, that adjustment is happening in 2019. The take-home point, gGastro users can use the MIPS reporting tool that is again built into gGastro for the full calendar year. So you are ready and prepared for 2016 and for 2017 with gGastro. Now here's the elephant in the room and the most important question that I feel we have as gastroenterologists and specifically for this company. How is GMed and Modernizing Medicine, how are we going to help gGastro users? Beginning in 2017, GMed will aim to add more GI-specific PQRS measures to your existing ECQM workflow to enhance your ability to report quality measures and demonstrate high-quality care. So let us take a step back for a moment. I want you to remember that MIPS composite score and the fact that quality is another name for PQRS and represents 50% of your composite score. So if we as gastroenterologists do not perform well in our PQRS measures, that 50% component of our MIPS score could be quite low, and we therefore may not be eligible for incentive payment or a positive payment adjustment. So we want to help you successfully not only report the quality measures, but demonstrate high quality care. And we do that by choosing measures that are specific to gastroenterology. If you recall in the earlier slides, existing ECQM or PQRS measures in gGastro, really it was just a colonoscopy screening that was GI specific. But many of you may know that there are PQRS measures that are more specific to GI, Barrett's esophagus, inflammatory bowel disease, hepatitis C. You may see that currently in your measures groups. So we need to add in the GI-specific PQRS measures. Secondly, the calculation of PQRS measures and reports will be automated. We had just spoken about a few slides ago about the fact that for many of these external registries, there's a manual entry process, and that is very time-consuming. We need automation, and that is what we will bring. Calculation of PQRS measures and reports will be automated. And finally, gGastro users will have the opportunity to see their ECQM and PQRS measures in reports as you do today. And that's very important. That is the feedback that we need. If you're not performing well on PQRS measure 121, and there's an adjustment, perhaps there's an error in the numerator calculation, or there's an easy adjustment to your workflow so that you perform better, you'll have the opportunity to see that dashboard and respond in real time, as opposed to waiting to 2019 where you see a MIPS composite score that you're not happy with. Okay, so those three steps, how do those steps help gGastro users? First, as I mentioned, currently, you as gGastro users have to manually enter data into other registries to attest for PQRS measures that are specific for gastroenterology and not available in gGastro. So that manual entry of data is something that we're targeting. We want to get rid of that as much as we can. By integrating with our own Modernizing Medicine registry and enhancing gGastro's existing ECQM reporting system, you will now be able to report PQRS measures in an automated fashion. This means less work for users. You're focusing less on manual entry, and you're focusing more on high quality care at a lower cost and getting a great MIPS composite score. And now I'm going to transfer control over to my colleague, Ida Mantashi.
Hi, everyone. So this is the dashboard you will see in gGastro for MIPS. This is currently under development, and hopefully by beginning of next year, you will be able to have access to it. And please send us your comment. We're looking forward to hear from you to see how you like it, how you take advantage of it, and if there's any improvement that you want us to implement. As you saw all over the presentation, there are 4 major categories. each one of them will appear as a card or scorecards in your dashboard. So quality is really your current PQRS, and as you can see, it's 50% your score. ACI, which is your current meaningful use, it contains of your 25% of your score. CPIA, which is clinical improvement, it contains 15% of your score, and the cost is 10% of your scoring. These numbers below are just an example of our test data. You will actually see your points or the number that based on your performance. It appears on your gGastro page. So if you click on any of those cards, the tool would automatically take you into the next page, which shows the details of how your scoring appears. So for example, if you click on the ACI, you will be able to go to this page. This is Advancing Care Dashboard. It shows you that there's like 3 yes and no questions. One of them is a bonus point, and the other 2 are required for you to answer. It has 2 sections for your scoring. It has a basic scoring section, and it's a performance scoring. Unlike meaningful use, which used to be just passing and failing, advancing care option, it just shows you the points or number. So even if you're not doing really well in one area, you are still eligible to report your numbers. Basic score is pretty simple. It contains 50 points, and performance score is more challenging only because the more you do, the better score you get. And that contains your 80 points. So altogether, you'll be able to score 130 points, which of course only up to 100 will be calculated. I know it's a little complicated, but we'll have a staff to help you understand if you need to understand the calculation, and basically you don't need to be worried about calculation. Our system will automatically take care of that for you. If you click on the quality score, it takes you to this page. This page basically is based on your ECQM page. It's very, very similar to that. You will see all the measures that you can report. It is important to know that they're going from 9 measures to only 6 measures. So you're required to report on only 6 measures, but it's better to report on the measures you're doing really well. So this page will have multiple options. As Julie mentioned, we're going to add more GI-specific measures to this page. And you will see how you're doing before you actually select which measure you would like to submit. This is clinical practice improvement activity. There are about 90 options for providers to select. Out of these 90 options, we're estimating about 30 to 40 of them are the areas that GI can take advantage of. All the questions will appear in your dashboard. It is on the attestation format, so you only have to say yes to it and get credit for it. It contains of 2 areas. Some of those consider high weighting, and some of them are medium. So if you are reporting some of the options that are in higher scoring, you only require to select 3 of them. If you are selecting the ones which are medium, you're required to report up to 6. As Julie already mentioned, you are not required to submit anything with cost. With that, I'm going to open the questions. One question from Margaret, can you provide this slide to the audience after the webinar? Absolutely, yes. The webinar has been recorded. It will be available to you with the slides. And again, please reach out to us with any questions. do the PQRS group measure still apply next year? It's a wonderful question. The answer is unfortunately no. MIPS will not support group measures. However, what it does support is gPro. So what we didn't get really into deep discussion was the gPro option. If you do select to report as a gPro, you are requiring to report on 4 categories as gPro. So there's no selection between them. Now, group measures, unfortunately, no longer available for MIPS. Again, these are just, whatever we show you when we spoke into it are not final roles yet, but from what we're reading, it will not be an option for MIPS. If CMS decides for some reason to change the roles, obviously we're going to stand behind it. Is the dashboard going to be available to all gGastro users, or it's billable add-on? Also, what version will be required to be used on? So another good question. The dashboard is available to all the users. Although the PQRS portion of it, it depends on which system are you using. If you are using the ECQM, it's free of charge. If you are using gGastro, obviously we don't have the exact scoring. So, however, you would be able to manually enter your score and get the final calculation into it. But the rest of them, yes, it's available to everybody. And which version is requiring? We are actually focusing on the beginning of the February, and most likely is 4.64. I'm not 100% sure about that, but I can get that after this call. I will let you know. Clinical practice improvement, will GMED filter by high, medium? So we are aware. Yes, absolutely. So it's going to be 2 separate sections. One of them will show all the high scoring, high weight, and the second section would have the medium. Also, as I said, we're not going to be able to show you all the 90 options. However, we are going to give you an option to manually enter anything from that. If there's an option that you see that you like and it's not in gGastro automatically visible to you, you can actually type it in and attest yes to it. So we have actually a search engine built into the gGastro, which will tell you if it's high or medium and how does it get calculated. Clinical practice improvement, it's the same question we have from Nola. And with that, I think we are at the end of the question.
Wonderful. I think Ida and I will give another 30 seconds for any of those on the webinar to type in any additional questions. During that time, I want to thank everyone for joining us for this webinar to discuss MIPS. Hopefully you have found it helpful. And again, this has been recorded and will be available to all those registered for the webinar. Another few seconds. If anyone has any last-minute questions, we'd be happy to field them. All right, well, hopefully I will see some or many of you at our GMED Summit in November. Until then, I look forward to my next webinar with all of you. Thank you very much for joining us.